Department I work in, we have radiation therapists who do a lot of the planning in our department, and what the physicists do is really just come in the end and do checks and make sure everything looks right. But I know in some departments, the physicists, particularly for Imrt and VMAT treatments, do a lot of the contouring, because some of the contours are really designed to help to optimize the treatment plan. So what I'll do today is just walk you through some of the different contouring things that as physicists we need to think about when we're planning Imrt and VMAT plans, and we'll take it from there. So I'll get started. Okay. The first thing that I just wanted to make very clear, and I read this only the other day, it's a journal article from quite a few years ago, but contouring impacts our patient survival. So there are quite a few trials where the data indicates that there's quite a significant difference in overall survival at 2 years for certain trials for patients that had deviations to the trial protocol. And a lot of those trial protocol deviations were due to issues around contouring and field design for Imrt and VMAT treatments. Sorry. And so what they found was part of these deviations also happen in departments that don't treat a particular site very often. So if your site treated a lot of patients per year, for a certain treatment site, you had less chance of having a deviation than if your department only treated a few of these types of patients per year. So it sort of shows that not only is contouring something that's really important to improve our patient outcomes, but also consistency and experience across the same thing. So repeatability of the same processes over and over also increases our effectiveness of the treatments that we're giving our patients. So I just wanted to highlight that before we got started on the actual presentation. So there's a few things we're going to cover in today's talk. So I'm going to introduce the AAPM TG263 report, which talks about contour I can't even say it, contour naming. It's much easier for me to say that. And the names that we give our contours, which is something that's really important for uniformity and a whole bunch of different reasons. So we'll then go through just some general guidelines for contouring our organs at risk and where we can find examples of organs at risk contours. So there's a few different websites that you can go to look up for references and get some practice in. We'll look at organ at risk and target verification and cleaning up contours, and then more specifically contours that we create specifically for treatment planning. And then I'll just quickly highlight what's going to happen with your presentation the next week when we're going to look at a specific method for planning VMAT treatments. Okay, so first of all, we'll look at TG263 for contour naming. So how you name your contours and your structures in a treatment plan is really important. So the American Association of Physicists in Medicine had a task group that released this report, number 263. And really what they were trying to say was uniformity and standardization across a department is really important. And then that standardization between departments, so globally around the world, is really important for a number of different reasons. One of those reasons is about transparency and knowing that who created the contours. So if you have a Ptv in your plan, was that a Ptv that was drawn by your radiation oncologist, for example? Was it a Ptv that a medical physicist came and updated and cleaned up a little bit after the radiation oncologist contoured it? Was it a contour that a radiation therapist or a dosimetrist worked on? So that's really important in having a history of who's been doing the contours in the treatment plan. Having consistent naming of contours and structures in your plan streamlines treatment plan checking, so that when you see the name of a contour in your treatment plan, you know exactly what that thing is. It's the same from plan to plan within your department. By having this consistent names, you get clarity. So the planned volumes that you have in your treatment plan will match the volumes that the radiation oncologist writes down in their prescription. And that's really important. If a radiation oncologist writes a prescription and for a volume, and that volume isn't even in the plan, then how do you know you're actually giving what the radiation oncologist intended to that patient? So that's really important. And also through consistency, any unusual volumes, so things that aren't standard or organs at risk or aren't things that you generally do for your treatment plans, they'll be more obvious to the team in the department as well. And that's really important, because if you have something that's unusual, it could mean that you've done something wrong. So it's the ability to pick up those errors more quickly. Again, if you have consistent naming conventions in your department, you can then start to incorporate scripting protocols into your planning system. So you can start to have automated planning and, machine learning and all that kind of stuff starting to be introduced in your planning system, which then will increase the efficiency of your treatment plans. So you can generate plans more quickly. So just as an example, there was a study done that looked at variations in naming structures between 16 different departments. And so, for example, the left optic nerve, out of 16 departments, out of 12 departments, there are actually 12 different versions of naming the exact same structure. The left lung had, for 12 departments, there was 1, 2, 3, 4, 5, 6 different versions of the exact same structure. So if you wanted to join a clinical trial, how would those trial people know what that structure was if it didn't match what everybody else's name was? And if you were trying to share a plan with another department, they might not understand what it is that you've written down in your naming structures. So through studies like this, the task group came up with this report and some guidelines as to how to name your structures. So there's a website here that tells you where you can find this particular document. I'm pretty sure it's free to download, or we might be able to provide that. So what this document does is it provides some structure naming conventions across different imaging and planning systems, and also naming conventions for different DVH metrics as well. The general rules that are given in the TG263 report, so they've decided, because different planning systems have different limits to how many characters you can have for your structure names, they've made a guideline that all structure names are limited to 16 characters or less, because some planning systems only allow 16 characters. So to make it uniform globally around the world, let's just keep it to the minimum. So the all structure names should be limited to 16 characters or less. And again, because of some different planning systems, spaces aren't to be used in your structure names. So instead you replace the space with an underscore. So just examples there of lung and bowel bag, and just using the underscore instead of having a space. So the Camel Case, where you have sort of two words joined together with two capital letters. So they should only be used when the structure name implies two concepts, but the concepts always appear together. So it's always the two words that you use consistently together. So cauda equina and seminal vesicles are always two words that you use together. All structure names need to be unique and independent of capital letters. So you can't have lung in all capitals and then lung in all little letters, because again, they could mean the same thing, but depending on the planning system, they can be different. So they need to be independent of capitalization, but they do recommend that the first character of each structure is capitalized. So rectum and bladder, for example. If we look just at the non-target structure rules, so we have obviously different letters for different orientations in the body. So L for left, R for right, A for anterior, and so on. Distal and proximal we've got there, and also for other structures through the body. So A can be for artery, V for vein, LM would stand for lymph node. So there's just in the document some really nice tables that kind of summarize that. So I've just grabbed a couple of those out of them for examples. And when you're writing down the structure, you always say the name of the structure and then its location afterwards. So you'll have lung left, or lung right, kidney left, kidney right. So that means when you have all your structures named together, you don't end up having all the left structures named at the start and all the right structures named at the bottom. It means you have your kidney left and kidney right sitting right next under each other in your structure list if it's done in alphabetical order. So that's sort of the logic behind some of those decisions. In terms of naming conventions for your target structures, obviously you've got your standard GTVs, CTVs, ITVs, Ptvs, and then instead of using absolute dose levels, task group recommend that you use relative dose levels if you have multiple dose levels. So in my department, we'll use high, mid, and low if we have multiple dose levels as part of the prescription. So some departments do like to use absolute numbers for their dose levels, And so the recommendation is you should use those values in centigrade. So if you want to have PTV with a dose level, so you'd have PTV underscore, and then the dose in centigrade. And that's the total dose, not the fractional dose in centigrade. The important thing with target structure rules is the prescription that is written by the radiation oncologist should always match the structure name in the plan. So you are comparing the prescription and the plan are exactly the same. And then there's also, if you've got target classifiers, so primary surgical bed, things like that, there's different subtext you can use after the PTV or CTV naming convention. So the task group report talks about these things called Z structures. And this is quite new. My department never used them before, but we've moved to this TG 263 report convention. And so Z pops up all the time now. Every single plan we have has these Z structures. The purpose of a Z structure is it's a structure that isn't part of the prescription. It's not, an organ at risk. They're really structures that are used purely for optimization. So they're a structure that you use to get a good dose distribution, but you're not necessarily worried about the actual DVH of that structure. So by putting a Z in front, it means all of those structures are moved to the very bottom of your structure list. And so all your important organs at risk and PTV structures that you're interested in for the DVHs and the doses are all sitting at the top of your structure list. The other thing that the Z structures are useful for is for original contours. So for example, if your radiation oncologist draws a PTV and you look at it and you go, well, they've drawn it outside the patient. It's going out into air. So we need to clean that up. You should always keep the original contour just to make sure that the intention of the radiation oncologist is then clear. So in that case, you would clean up the radiation oncologist structure and save that as the PTV. And then you might keep the original contour as a Z PTV and then the radiation oncologist name, just so that you know who did the contour and that it remains as part of the plan. And so you've got the history of the contours there as well. And the other thing you can use Z structures for is your high, low dose regions that are used for optimization. So we'll cover these Z structures in more detail later on in the presentation. So we'll cover those specifically. So that was a very quick overview of what the TG26 I've got the name 263 is all about. So I recommend that as a department, you get a copy of this and then you write out the guidelines that are relevant for your department and you start moving towards that standardization of that particular report. So my department did this probably, I would say 2 years ago, feels like 2 years ago. And it's only just now we're all starting to get on top of it. I'll look at structure lists and I'll know exactly what's going on with those structure lists. So it does take time and a little bit of perseverance, but it is really important that you get that consistency and that there's a universal sort of naming convention that we're all using so that we can all understand each other when we're looking at plans. So I'll move on now to just some general guidelines around organ at risk contouring. So first we'll talk about the actual imaging of the patient. So all your patients should have like a CT simulation scan with the patient in the treatment position. So that will be just the scan in your department CT scanner. You need the CT scan to create your electron density to be able to calculate the dose. So all patients should have this. Obviously, there are other scans. So things like MRIs or PET scans or PET CT scans that can also help to delineate the target and also some of the organs at risk. So in your treatment planning system, you may not only have the CT simulation scan, but you might also have other scanning image sets for your particular patient. Sometimes those other scans, the patient isn't in the treatment position. So registering those two scans together, so registering your extra scans to your CT simulation scan can sometimes be really challenging if the patient's not in the same position, but you need to register them as accurately as you possibly can. Some of the big areas of uncertainty in any patient treatment comes down to contouring and image registration. They're sort of two of the areas as accurate as your treatment delivery might be. If your contouring isn't right, or if your image registration isn't right at the time of planning, then the uncertainty in your treatment delivery can be very large. So these things are really important. It's always advisable that you contour at least your organs at risk based on anatomy in a CT simulation scan, because you know that the patient is in the treatment position and everything should be reproducible at that point. So, however, obviously things like MRI can also help with organs at risk contouring, particularly in the cranial area. So in the brain, all the substructures within that are obviously much easier to define when you have an MRI rather than a CT. So you can use those also to help with your organs at risk contouring. If you're lucky enough to have a 4D CT scan of your patient, if that's needed, depending on the treatment site that you're looking at, we recommend that when you're contouring your organs at risk, you use the mean or average intensity projection to contour your organs at risk. So not the maximum or minimum intensity projection, which you might use to create your ITV. So you'd always use the mean or average intensity projection to contour your organs at risk. So the alternative is you have a 4D CT scan and then you have a standard 3D CT scan and you register those together and you contour your organs at risk on the 3D. So that just means that any motion artifacts will be taken into account in your organs at risk contours as well. Okay, so why is all this contouring super important? With Imrt and Vemmat treatment plans in particular, accurate contouring of your targets and your organs at risk is critical because these are the contours that are used by your inverse treatment planning algorithm. So if you're manually planning, the contours are less important because you have control of where the beam goes and where your treatment fields are. When you're doing inverse treatment planning in your planning system, it's your contours that define everything within the treatment plan. So if your contours aren't accurate, it means your treatment plan is not going to be accurate either, and you won't get a great optimization for your patients. So if any part of the patient isn't defined with a contour, so let's say we're treating a prostate patient, we've defined the prostate, we've defined the bladder and the rectum and the femoral heads, but we haven't defined anything else. The planning system doesn't know whether you're happy to have high or low dose in those regions. So it's really important that there's a lot more contours in an inverse treatment planned patient treatment, because as smart as the algorithm is, it can't read our minds. And so we need to tell it absolutely everything. We need to say this part of the body is actually normal tissue and we don't want a lot of dose in there. If you don't tell the planning system that, it might think that we're quite happy to have 150% dose running through that part of the patient. So that also means that we might often have to have additional structures or contours that are put on our patient purely to help improve the dose distribution. And they're our optimization structures, or our Z structures, that we'll cover in just a little bit. In terms of organ at risk contours, obviously contouring takes a long time and everyone's busy. The workload dramatically increases when you move to Imrt and Vemmat treatments. So sometimes there's got to be a compromise. So if you don't have time to make everything perfect and all your contours perfect, you need to prioritize. So the organ at risk contours that we want to be perfect are the structures that are immediately surrounding our target. So for example, in the case of the prostate, the bladder and the rectum are sitting right next to our target. So having those contours and knowing that they're accurate is really important. Imperfect is okay if the structure is far away from our target. So obviously the femoral heads, whilst they're still super important and much easier to contour, to be honest, because they're bone, they can be slightly less perfect because they're sitting further away from our target. So all our high dose is in our target. And that's sort of the area that we want to manipulate more. So further away from the target, you can be a little bit less than perfect for the structures if you have time constraints. If you don't have time constraints, obviously making everything as perfect as possible is the way to go. Obviously, some planning systems have auto contouring or auto segmentation, and these are super helpful tools to get through all of that, all the contouring that's needed, particularly around the brain and the head and neck that have so many tiny structures. Contouring can be incredibly painful trying to do all of those and incredibly time consuming. So auto contouring and auto segmentation is really helpful, but you shouldn't rely on it as being perfect. So you always need to double check any auto contouring or auto segmented contours in your system. Again, if you're using auto contouring, focus on those structures that are closest to the target. Excuse me. So pay more attention to the proximal bowel in a pelvis case than bowel that's further away. So don't spend, I wouldn't say waste time, but don't spend too much time focusing on those organs at risk that are further away from you. So I'm just going to give you now a couple of examples of websites and different places you can go in order to look at organ at risk contouring atlases and some different websites where you can practice contouring. So this website I think is probably the most useful. So it's the econtour.org website. It has libraries of cases covering different treatment sites. So you can see, you can choose a different site down the left-hand side. And even within each individual site, they have a lot of different cases within them. This website's free. You do need to register, but that just takes a few minutes of your time. And this website is specifically targeted to radiation oncology, which is what makes it really, really helpful for us. Another example is this website called Sectional Anatomy. It's free and you don't need to register. It doesn't have as many cases. So the ones listed here are probably the main ones that you might be interested in. And this was a website developed for radiologists. So it's probably less informative from a radiation oncology perspective, but still really interesting to see the different imaging types as well and the structures that you can see within different imaging types. So it's worthwhile visiting that one as well. So this one, prostadoodle.com, again, it's free, no registration needed. Excuse me. This one is just targeting the prostate, and it has a great prostate atlas, and there's also a contouring program that you can use, and you can get feedback on the contours that you create in the contouring program. I don't know how quickly the feedback comes. This website's been around for a little while, so they might not be monitoring as much as they used to. But certainly if you're starting off Imrt and Vemma, you start with the prostate. It's just what you do. Everyone starts with the prostate. So if you're just sort of starting to get into Imrt or shifting from Imrt to VMAT, this is a really useful site for the prostate information. And then we've got NRG Oncology, which is sort of a side branch of the RTOG website. So this is, again, free. You need to register to get access to the contouring atlases within this site. But again, it's radiation oncology specific. There's a nice list of different sites there as well that you can look at throughout the body. So that's actually really nice. I would say that eContour and this one are probably two of the most helpful sites that you can look at in order to better understand, I guess, anatomy for different imaging types and the contours that are important in radiation oncology. Okay, so what we'll look at now just briefly is organ at risk and target verification and cleanup. So when a radiation oncologist comes in, the radiation oncologist should always be doing the contouring. This is what they learn. So radiation oncologists, when they contour, they follow protocols and they look at atlases to contour, and they look at diagnostic information and pathology reports and all that stuff that makes no sense to me to contour the target in particular, and also the organs at risk. But like everyone in a radiation oncology department, our radiation oncologists are busy. They're seeing many, many patients. And so, often when they sit down to do contouring, they're being pulled in 5 different directions. And so you can never assume that a radiation oncologist is getting everything perfectly right. As I said before, some departments can use auto contouring or auto segmentation tools. And also, as I said before, targets and organs at risk could be contoured on image sets that aren't the CT simulation scan. So if you have an MRI, the radiation oncologist might go, I love this MRI, I can see all my stuff. And so they'll just draw all their contours on the MRI rather than the CT scan. And we're also aware that targets and organs at risk contours can be interpolated rather than contoured on each slice. So particularly for things like bladder, rectum, you contour one slice, you skip a few, you contour another, and it's interpolated between those slices, which is a time saving. And the interpolation tools are usually pretty good. But because of all of these things, every single contour that's on your patient plan should be inspected prior to starting any treatment plan or even starting any optimization contouring. So you need to double check and clean up if needed. Any organs at risk that are next to or overlapping targets. So sometimes, a radiation oncologist can do a big loop and say, we're treating the bladder, but then they've also contoured half a piece of bowel as well. So there needs to be a discussion with your radiation oncologist. Did you intend to have the bowel as part of the PTV, or, do we need to clean that up and remove the bowel from the PTV? Another thing that is notoriously done by everybody is contouring organs at risk and targets near the skin surface. Tumor does not grow in air, so there's no point contouring a target that sits outside the skin surface. And if you have a target that sits outside the skin surface, you're not going to be able to optimize it properly, because the optimizer is going to try and be putting 100% of your prescription dose in air, and it can't work. The optimizer will just blow a fuse and go, I can't get dose in there. It's not giving me any dose because there is no tissue. So particularly organs at risk and targets near the skin surface need to be considered. So my department, we tend to crop back any targets and organs at risk for about 3 to 5 millimeters from the skin surface, just so that we're safe and we know that we're not putting those targets out into the air. Again, you need to double check any auto-segmented contours, that they haven't been put in a random place that makes no sense, or they haven't been over-contoured or under-contoured. You need to check your image registration. So it's very easy to copy contours from an MR to a CT, but if the registration of those two data sets isn't right, then the copied contours will be going to the wrong position on our patient, and we could be doing geographical misses of our target in that case. Again, we need to check our contour interpolation between slices. Planning systems are really good at that these days. They're getting better and better at doing interpolation between slices, but they aren't perfect, particularly contours that rapidly change from slice to slice. The interpolation can often be, someone's sharing their screen.
Yeah, the second. So I would like to remind you, please, to be careful with your mics and screen sharings. Just want to try to stop
Hang
this.
on, let me see if I can get it back. There we go. Thank you. Okay. So we need to check our interpolation between slices, particularly if we have contours that vary quite rapidly from one slice to another. Oops.
So
clicking it back. And the other thing we need to check is just a sanity check of our organs at risk naming and target against our naming convention, and also that the target location matches the prescription and diagnosis. So if our radiation oncologist has written a prescription for upper left lobe of the lung and they've contoured the lower right lobe, it's time for a conversation about where is our target? What are we trying to treat? So you do need to always go back and have a sanity check that your prescription matches what you're doing in the planning system as well. So those things are really important before. I'm not sure who that is.
I think it's already taken care of.
Okay, great. So these things are really important to do before we even start to think about doing any kind of optimizing on any of our treatment plans. Okay, so now we move into the nitty-gritty hardcore stuff and contouring for treatment planning. So like I said before, sometimes it's necessary to contour a lot of normal tissue near the PTV that we wouldn't normally contour if we were doing 3D conformal planning or forward-based planning. But these contours are necessary to tell and to help the optimization algorithm whether or not you're allowed to deposit high dose in that region. So the algorithm will assume often that if something isn't contoured, you don't mind whether there's high dose in that region or not. So creating contours and contouring everything is really important for IMRT and VMAT planning, because sometimes high doses can be delivered to uncontoured normal tissue during optimization. So when we're contouring, so in order to lower the dose to all of the normal tissue surrounding our target, we have to contour it. And oops, let me go back.
Sorry.
That's okay.
You got it right? Okay.
Yeah, I'll just have to keep going backwards and forwards. I'm not sure who's accidentally sharing their screen all the time. So yeah, in order to keep the dose surrounding our PTV or our target as low as we can. We need to contour it, and we need to put dose constraints on that when we're doing our optimization in our treatment plan. So these are things called optimization only structures.
Yeah, please just try to get it back and working on it.
Okay, thank you. And so these are what we call optimization only structures. And so they're structures that are used solely to control the dose distribution during optimization. So we can call those physics contours or dosimetry contours. These are our Z structures that we talked about before. So typically, I don't know if we can see them in the participant list.
Yeah, don't worry, I'm on it.
Okay, thank you. Let's keep going. Apologies to everybody. So often our optimization structures are expansions of our organs at risk or combinations of our targets and normal tissue. So by defining the intersection of our target and normal tissue as different structures, we can put different constraints on each of those regions. So we can create controlled dose gradients. So it's not only about, I guess, keeping the dose as low as possible, but making the dose drop off around our PTV as steep and as uniform as possible, and also making the dose within our PTV as uniform as possible. So these structures give more information to our optimizer so that it can create a better plan for our individual patients. So this is just an example of what an optimization only structure could be. So in this case, the red contour is our PTV high. And then we also have a PTV low in yellow. So the prescription dose to the red is higher than the prescription dose to the yellow. We have our left parotid, which is this structure here in green and blue or cyan. And then what we do is we have an optimization only structure, which is our Z structure. So we have the Z in the front. It's our left parotid subtracting the PTV. Or we could call that our Z structure, left parotid opti, meaning an optimization structure. So that's this structure here. So it's the left part of the left parotid that does not exist within the PTV. So the radiation oncologist in contouring this has decided that actually this part of the parotid actually forms part of our PTV. So it needs to get more dose than this other part of the parotid structure. So we now create a structure that exists just outside of our PTV, and we'll use that in our optimization. So when we're doing our contouring, what we want to do is use knowledge of the theoretical dose fall off around our PTV to predict where we can most appropriately push dose harder and where we can make the best use of our optimization structures. So if that's done right, you can create contours in your plan so that the optimization algorithm works as efficiently as possible and gets you the best possible plan. Obviously, in any of the examples I'm sharing, different institutions and studies might require slightly different dose criteria for PTVs. So if I've put something in here, don't take this as the gold standard dose that you should be using. This is just examples. So when we think about our theoretical dose fall off, there's sort of two different fall off doses that I usually think about. So if we've got a small volume, the dose fall off is usually a lot steeper. So particularly in brain cases, head and neck cases, you're usually a small volume, you can have a really steep dose fall off around that volume. So we'd assume the dose fall off should be around 10% of our prescription dose per millimeter away from the PTV. So for example, let's say our PTV is covered by the 95% isodose. The 50% isodose will sit around 5 or 6 millimeters away from the edge of the PTV. So we're dropping 10% per millimeter as we move away. If we have a larger structure in the patient, so a larger PTV, we usually use the rule of thumb of around about 5% dose drop off per millimeter. So if you had a ring around a PTV and the edge was sitting 3 millimeters away, that PTV or that structure around the PTV should have a maximum dose of about 85% because we're dropping 5% per millimeter. Obviously, the rate of dose fall off decreases with distance from the target. So this doesn't necessarily apply if you're very far away from the target. But again, those areas we're less concerned about. We're really concerned about the areas immediately around our target. So these rules would apply then. So they're really useful numbers to have in your head when you're contouring and also when you're creating your dose constraints in your optimizer. So some of the most common optimization only structures that we would use in a treatment plan, optimization structures around our PTV. So we call them PTV opti structures. So they're things like rings and rinds, creating corners, and if you have a PTV within a PTV. And then we have our organ at risk opti structures, and they're often called planning organ at risk volumes, so PRVs. There are also extra structures, and they can be called different things. So they can be avoidance areas, dose tuning structures, cold spots and hot spots. I'll also discuss if we've got overlapping PTV and organ at risk structures, a little bit like the example we just had before with our parotid. And there's also what I call contouring for density correction, which is not really about defining a structure, but it's information you need to create a more accurate dose calculation. So the first one that I just wanted to discuss was the rings. And this is the one that if you've done any IMRT or VMAT planning, you've probably already used this. Rings are super common. So rings are basically what they say. They're bands that you put around the PTV in order to help dose fall off and dose conformity within the PTV. So again, you follow the rule of thumb, depending on the size of the PTV, of your 5% per millimeter or your 10% dose fall off per millimeter. So for as I said before, a ring that was sitting 3 millimeters from the edge of the PTV should have a maximum dose of 85%. In my department, we usually make rings about 5 to 10 millimeters thick. And some departments like to leave a small gap between the PTV and the ring. And this is to help the optimizer, because if you have one structure and you want, let's say 60 gray to the PTV, and then you want the dose to drop off really quickly, you're going to have two competing structures sitting exactly side by side, and the optimizer sometimes struggles with that. So some people find if they leave a small gap, so 1 to 2 millimeters, and then put a ring around the PTV at that point, it just leaves a margin enough that the optimizer then has some wiggle room to play with and create a better plan for you. The next one we're going to look at are rinds. So sometimes the optimization algorithm can struggle to keep the dose at the edge of the PTV within tolerance. And this could be because you've got nearby organs at risk, that you've got low doses, you've put dose constraints on, or you've got a normal tissue optimization. So I don't know if NTO has been covered in any previous lectures. So I'm pretty sure all planning systems have it. It might be called something different. So the normal tissue optimization helps us in that you define your body contour. So you've told the system, here's my whole patient. You've clearly defined your targets within the patient and you've labeled them as such, as a category. And so what the normal tissue optimizer does is say, okay, everything within the body that is not a target, I know is normal tissue that I should give as minimal dose as possible to. So the NTO is a game changer in a lot of ways, because it has avoided the need to create millions of contours. Sometimes the NTO works, sometimes the NTO doesn't work. It sometimes depends on the position of the PTV in the patient, and it sometimes depends on the shape of the PTV. So you may find that you rely heavily on the NTO in some cases and it doesn't work in others. So that's where you might need to use a rind just to keep the dose within your PTV uniform. So I guess the rind is the opposite of the ring. So it's a ring on the inside of the PTV as opposed to a ring on the outside. And so you're creating a thin volume just on the edge of the PTV, and you can create your own dose constraints and objectives for that particular region. So the optimizer can focus on that area more efficiently. We tend to use about a 5 millimeter rind if we use them. I have to say that we don't tend to find rinds very helpful with VMAT plans, but they are helpful in IMRT plans. Different departments might have different experiences, but in my department, we found that we don't tend to use the rind very much at all, if at all, for our VMAT plans, but we still find them somewhat useful for IMRT. Corners. So corners are, if you've got an unusually shaped PTV, so this is often pelvis cases with nodal involvement. So the radiation oncologist has got a PTV low that's sort of a horseshoe shaped volume. And so sometimes the optimizer struggles with those corners, those edges, the sort of legs that you see in your PTV. So what you can do is create a corner PTV and then again use the optimizer to focus on those areas to make sure that you get the dose needed into those sort of thinner parts of your PTV. So in that case, you call it a Z PTV dose, we call it opti, and we call it corners. So these Z structure naming conventions can be a little bit more flexible from department to department because the Z structures are not, you're not interested in DVHs for those structures. So there is a little bit more flexibility with how you name those structures because it's not part of the prescription. If it was a clinical trial, nobody's interested in what dose those structures get. They understand that they're purely there as an optimization aid. So the naming conventions there can be a little bit flexible. If you have a PTV within a PTV, so you've got a PTV, say high and a PTV low, sometimes the optimizer struggles because you've got two different dose volumes within each other. So it's often helpful to create a second structure where those two structures themselves are a little bit separated. So in that case, you'd create a structure that had a margin between the PTV high and PTV low. And there's a formula here that you can use to determine what size margin you should use based on the different doses that you're looking at within your PTVs and also the average dose fall off that you're expecting to see around your PTVs. So we tend to start with 5% rather than the 10% option in these cases. So here's just an example of that. So we have a PTV high, which is this area in blue. The purple shaded region is our PTV low. And so from that, we calculate what margin we need to put around our PTV high to create our opti structure. So we've got our 45 over 54, assuming 5% dose fall off. And it says we should use a margin of 3.3 or we'll use a 3 millimeter margin. So we then create this yellow structure, which is our Z PTV opti for our low dose PTV. So moving away now from the targets and things we can do with our target, we'll look at our organs at risk. So certain organs have very fixed dose constraints. And so often if our PTV is sitting near those particular organs at risk, we'll create a planning organ at risk volume. So it's just a bigger volume that sits around that particular organ at risk. So for example, all the stuff with our optics, so our optic chiasm, the lenses, we've got the optic nerves, and then things like the cochlea and the brainstem will give a 3 millimeter margin around those structures for the planning organ at risk volume there. For the spinal cord, we tend to use a 5 millimeter margin for the PRV because it's a little bit more, I guess, important. And then there's actually a naming convention within the TG263 report that talks about how to name the PRVs. So if we were doing, for example, the brainstem, it would be Z because it's an optimization structure, brainstem, and PRV with a 3, indicating it's a 3 millimeter margin. Same thing for the cochlea. So we've done the cochlea, it's the left cochlea, it's a planning organ at risk volume with a 3 millimeter margin. So by having these structures, that extra margin just ensures that the risk of high dose going into those really critical areas is minimized. So just an example in this case here, we've got our brainstem here contoured in orange, and then we've got our brainstem PRV with a 3 millimeter margin in pink. Looking at this one here, we've got our right cochlea contoured in blue with the PRV with a 3 millimeter margin contoured in light blue there. Again, you can see our optic nerve is in brown with a PRV in orange there, and the same thing, red on this side with a brown PRV around it there. So you'll see that quite a lot in head and neck cases, and that's really useful. It's to ensure that your organ at risk does not get any high dose at all. So now we have these extra structures. So these extra structures are not related to a specific organ at risk, but they are volumes that help the optimization algorithm control dose, both outside or inside the target. So we can create structures within our normal tissue that we can use as an avoidance region or a dose tuning area. And then we can also create within our target hotspot and cold spot areas. So if you do, let's say we create a dose and your target has some hotspots in it, you could then contour those hotspots and then re-optimize by defining a lower dose objective to those hotspot areas so that you get more uniform dose in the target. If your target has cold spots, again, you'll contour the cold spots and create a higher dose optimization objective in order to get that uniform dose in the target as well. It's best not to overuse particularly the hot and cold spot structures. You don't want to have a target that has 50 different hot spots in it or 50 different cold spots. You generally only use it if there was 1 or 2 spots that you were just still struggling to get rid of. So if you do your optimization, you find your target has a lot of hot spots in it, it's probably better to re-optimize with different dose criteria altogether across all of your structures. So improving your overall planning technique rather than trying to address all of these individual spots over time. So this is just an example of a dose tuning structure for, again, a brain case. So we have a really big PTV here in red. We've got our brain stem in orange with the PRV 3 millimeter margin in yellow. Again, we've got our chiasm here in blue with a 3 millimeter margin PRV in cyan. And then in between, we've got this dose tuning structure. And so this is a little bit like a combination of the corners. Like you could say there are corners up here, but what we're trying to do with this tuning structure is to further reduce the dose inside this part of the brain. It's obviously critical structures, but you've got your PTV wrapping all around it. And so by adding this additional structure, you can further push the dose down in that sort of well inside the PTV. So those tuning structures are used a lot in my department. So you would only have 1 or 2 tuning structures within a particular plan. You wouldn't go and put 10 tuning structures all over the place. Again, it would be about wise positioning of those tuning structures and choosing the right ones that are going to have the most impact in your treatment plan. So overlapping PTVs and organs at risk can be confusing, and I would certainly recommend that if you look at a plan and you do have overlapping PTVs and organs at risk, that you have a conversation with your radiation oncologist to specifically make sure that that part of the organ at risk should be within the PTV, or whether it was an unintentional contour that caused it to be within the PTV. So sometimes it happens that parts of an organ at risk do fall inside a PTV due to the GTV to PTV margin that you need to use. So that tends to be what happens. You have a small GTV with a larger margin around it to create your PTV, and then that happens to fall within an organ at risk. So there are certain organs at risk, for example, optics, your brainstem, your spinal cord, where there is a maximum dose for that structure that must not be reached. So in that case, what we need to do is actually subtract, the organ at risk plus a margin from the PTV in that case. So again, when we think about the margin that we're going to subtract, we use that same formula we looked at before, but instead of PTV high and PTV low, it's our organ at risk dose over our PTV dose. In this case, if we're thinking about the head, it's often a small PTV, so we'd use maybe a 10 millimeter per 10% per millimeter dose fall off in that case. So just as an example, we'd look at the brainstem. So the brainstem with a maximum dose of 54 gray falls within a PTV that's prescribed to 60 gray. So we can't let the brainstem get to 60. So we're going to have to subtract out the brainstem plus a margin to ensure that our brainstem does not get more than 54 gray. So we'd use our formula here with our 54 over our 60. Let's assume 5% per millimetre dose fall off. And we see that we need to use a margin of 2 millimetres in that case. So here's just a visual example of that. So we've got brainstem chiasm and optic nerve cannot receive more than 54 gray within a PTV prescribed to 60. So we've got our 2 millimetre margin. And so what we would have is our brainstem here in orange. We then have our 2 millimetre margin around the brainstem in yellow. Same thing for our chiasm, with a 2 millimetre margin around that in green. And then that volume is subtracted from our PTV, which is in red. So we then have this optimization structure that will be the PTV we use for optimization, noting that this part of the PTV will not receive 60 gray, but it is still considered the PTV because of the definition of how it must be drawn. So it's a difficult concept to get. And I really recommend that when you're doing this, you're sitting with your radiation oncologist to make sure that everybody's clear, particularly in the early stages, about what you're doing when you're creating these structures. A more challenging case is if you have an organ at risk where the mean dose must not be reached. So this is a little bit more challenging to do in practice. I don't tend to do it very well, so I don't even have an example. But the trick in this case is you create multiple PTVs minus organs at risk. But in this case, rather than just creating a ring around the PTV, you create shells. So a shell would be just the ring itself minus the organ at risk in the middle. So we create shells of increasing thickness from the organ at risk. So you'd have a shell with 0, and then 2, 4, 6, as many shells as you thought were necessary. And then you would end up with a ZPTV, which was your original PTV minus the sum of all these shells that you've added into your plan. And then what you do is during optimization, you set a lower limit on the ZPTV and the ZPTV minus organs at risk, so all your shells, with an equal weighting on all of them. And so if the mean organ at risk dose isn't achieved in your plan, then you would delete the first shell, so the one closest to the organ at risk, and then keep the same weight for the other organs at risk and try and re-optimize again. So by removing that inner shell, because that inner shell is basically not working at this point, so you then increase the focus on those shells further out, and you continue to do that until you get a compromise between your PTV coverage and the mean organ at risk coverage for that particular organ that sits inside the PTV. Okay, at this point, we're going to run a Zoom poll with our first question. So I'm going to stop sharing so that poll can be run, but I'll just read out the question first. Oh, so here we go. I'll just stop sharing while we do that. So for inverse treatment planning specific structures, so the things we're talking about, rings and rinds, are used during the planning process. So these structures are used to report doses and 8 criteria, created during the treatment planning process by planners, contoured by physicians, or must be reported in the DVH. So physicians can review and approve the plan. So we'll give it a little while and see the numbers coming in. We've got about half of you have done it.
All right,
Okay.
maybe some couple of extra seconds. So about 2/3 of the participants have already responded, and it seems there's quite some consensus as well.
Yes, I think there's a clear winner in this case. So we might end that poll.
Okay, so yeah, that's it. All right.
Perfect. I don't know if people saw the result, can see the results of that.
I think I can share them. I don't know if you can see it already.
Okay, I'll just read out. So 75% of you chose option B, which is awesome because that is the correct answer. I think it was a pretty easy question, I have to say. But so, all the things I've just been talking about, all of our optimization structures, all of our Z structures, we don't use them to report doses and meet clinical criteria. They're not part of the prescription. We don't look at the DVHs. Well, we do, but we don't need to report them. They are created during the treatment planning process. And almost always by the planner, whether that be a dosimetrist, therapist, physicist, whoever's doing it. They can sometimes be contoured by physicians, but usually by the planner. But the physician should be consulted to ensure that they're in agreement with the contours you're creating. And we don't need to report the deviate for those. The physicians are only worried about the volumes in their prescription. So it's those things that we need to report, not these optimization structures. So perfect. Okay. Oops. So I'll go on. So just this last one, thank you for bearing with me. I know we've run a bit over time. This last one I just wanted to talk about is contours for density correction. So if you're using the C-type dose algorithm or dose calculation algorithm that was sort of talked about, I think maybe lecture 2. So your more Monte Carlo, your more greater modeling based algorithms, you might need to create contours that help to improve the accuracy of the dose calculation in the patient. And that this is particularly in areas where you have high density in the patient, and also areas where you might have low density or transient low density. So in terms of high density structures, this is often your prosthesis or dental fillings in the mouth, you know, those types of things that are, I guess, high density. So ideally what you want to do is avoid treating through any high density material. So if you're treating a prostate with a hip prosthesis, you would, if you're doing IMRT, you would have beams that were not passing through the prosthetic. If you're doing VMAT, you'd create an avoidance region around that part of the prosthesis, because dose calculation through high density material is not very accurate. And even if it is, the material absorbs so much of the radiation, you end up with hot spots sitting just in front of the high density material and that cold spot behind it. It's a nightmare to deal with. So it's best just to avoid treating through the high density material at all. But having said that, these structures should be contoured and assigned to a set density, particularly if your CT scanner can't accurately do this. So if your CT scanner, if the electron density to HU value curve from your CT scanner doesn't go all the way up to those high density materials, you might need to override the value that your CT scanner gives you and put that into your treatment planning system. You might also find that tissues surrounding high density structures will have artifacts in it. And so then you also have to contour those artifacts and override them with a density. So just as an example here, we've got a patient that has high density teeth implants up here, and they also have a titanium spinal implant down here. So you can see some rods there. So what we do in my department is we contour the teeth and also the spinal implant, and each of those are assigned a different density because they're different material. So, you know, we've assigned it a slightly lower HU, and that's the number that we've worked on with, you know, a series of experiments looking at different materials and what HU values they should have. And again, the teeth here are assigned a uniform Hounsfield unit. What we've also done with this patient is contour the tissue surrounding it that had all the streaking artifacts in it, so that those artifacts were taken out of our dose calculation algorithm and they were given a uniform tissue density. So this is our PTV here. So whilst we would avoid direct radiation coming in through the teeth and also in through the titanium implant, that surrounding tissue here would still be part of the dose calculation. So it was important that we overrode those artifacts for that. In terms of low density structures, I think the biggest area that we look at in my department is bowel gas. So bowel or rectal gas tends to be transient, and it will vary throughout the course of a patient's treatment. So if there's bowel gas inside the patient for their CT scan, it doesn't mean that that same gas is going to be there for every single fraction of treatment. It doesn't mean there'll be no gas, but we don't know where that gas may be inside the patient. That's one thing that we really can't predict. So there's a couple of things that bowel gas can do. So if the air cavity is inside your PTV, what will happen is the optimizer will increase the fluence. So it's trying to put dose into that air cavity where there is going to be no dose. So it's trying to achieve a dose constraint that is unachievable because it's trying to put dose in air. And so if you then plan that, and then if during treatment the air is not there, it's going to actually create a significant hotspot in your PTV because the planning system has pumped dose into this air, this bubble. The bubble's not there, and so it's now pumping dose into tissue. So that can cause quite a significant hotspot in the PTV. If your air cavity is sitting outside the PTV and you've got radiation beams passing through it, the optimizer will decrease the fluence in that region because there's less tissue that the beam passes through. So it doesn't need to have as much fluence. And so if the air is not there during treatment, it may create a cold spot in the PTV because it's not getting enough dose because it was never thought that it needed to. But the air cavity outside the PTV and the cold spot that it creates in the PTV is less significant than if you had the air cavity inside the PTV, but both should be corrected if you can do that in your plan. So in my department, there's a couple of rules that we do in terms of contouring air or low density structures. So we contour the gas in the patient and we assign it the same density as the surrounding tissue. And we do this for air cavities of greater than 1 cc that's fully inside the PTV or partially inside the PTV, or within 2 centimeters of the PTV, and it's within the path of the beam. So there's different criteria. So, but you'll get these slides so you can review this. It's a bit hard to take in the next few minutes. We also contour gas if the air cavity is greater than 5 cc and it sits more than 2 centimeters from the edge of the PTV. And it's also within the path of the beam. If it's not in the path of the beam, it makes no difference. You can ignore it. We also contour gas if we have multiple air cavities that are below the thresholds that are listed above, the 1 or the 5, but are close enough to each other that when you add them together, they exceed the thresholds. So it's a little bit hard to get your head around, but I've got a couple of examples that might help explain that. So here's a couple of examples when we should contour the air cavities. So we've got our PTV here. This is obviously a PTV low. It's quite a big volume. And we've got an air cavity here. So it's partially inside our PTV and it's greater than 1 cc. So in this case, we would contour this air cavity and we would assign it a density of tissue. In this case, here's our PTV here in blue. These are sitting sort of more than 2 centimeters away individually. Each of them is less than 5 cc, but because they're close to each other, we add them together, it's more than 5 cc. So we now have multiple cavities, more than 5 cc in volume, more than 2 cc from the PTV, and our beam will be passing through this area. These really tiny air cavities that you can see in the bowel, we don't worry about those ones so much because you could be forever contouring tiny bubbles of gas in the patient. So we're really only looking at the significant volumes inside the patient. So here's a couple of examples where you don't need to contour the air cavities. If you have time and enthusiasm, obviously you still can. There's no harm in doing so, but obviously everyone is super busy, and so if you don't have time, these aren't so critical. So here we have an air cavity that's very small. So it's less than 1 cc. It's within 2 centimeters of the PTV, but it's less than 1 cc. So we would consider that too small to be of clinical significance or clinically impacting on the PTV. Here again, we have 2 really small air cavities that are less than 1 cc in total. Even though they're sitting within the PTV, we consider them too small to be of clinical impact on our PTV dose distribution. So yeah, so that's just a couple of examples of other contours that you might be putting in your plan, and they're not necessarily they're not using them for optimization, but you're just using them to improve the dose calculation accuracy in your patient. So I've just got one more Zoom poll question for you. This is a simple 50-50 chance. So I'll stop sharing. If we can run that poll, please. Okay, so it's a simple yes/no question. So we've got a patient being treated on the mediastinum and esophagus. We're using VMAT, and they have dental fillings of a really high density. So do we need to contour those dental fillings and the artifacts for this particular patient? So this one doesn't seem quite so clear cut.
Maybe some couple of seconds. There's about 50% of participants already.
Perfect.
Well, distribution seems quite different to the previous one.
Yes, I think I've set a challenging question this time.
Yeah. Yeah. Right. So we have about 2/3 of participants already. Let's say, see around 50.
That's it.
All right. 10 more seconds. All right. Okay. I'm just
Okay.
sharing results. So I don't know if you all could say it, but anyway, I think Claire, you have the results with you, right?
Yes, I do. Yes, I do. So we've got 52% of you said yes, and 48 of you said no. So this is obviously a really challenging question. And I guess you have to know your anatomy a little bit to answer this question. So we have a mediastinum esophagus patient we're treating with VMAT, and they've got fillings in their mouth. Okay. So the answer in this case is no. So in this case, here's our PTV here. We've got esophagus, mediastinum, PTV. We've got VMAT running around the chest area. So we do not have any beam passing through the jaw where the teeth are. So even though they do have high density material in them, even though there's imaging artifacts in there, there is no beam passing through this area. So we don't need to contour those. Okay, so I think that was a good question. So what I wasn't trying to trick you up, but just show you an example of where sometimes you have artifacts and issues in a CT scan, and it's about determining whether it's clinically relevant or not to contour those things. So in this case, it's not clinically relevant because it's not within the path of the beam. So thank you for answering that question. So with that, I'm just going to briefly talk about what's happening with the next session. So Adam Schulman, who's one of our great educators with RCC, is going to be running a session with you to talk about a method of VMAT planning that he uses in his department. So there's a Google Drive with just a document that describes the method that Adam uses for his treatment plan. Hopefully during the week, I'll go in and edit the document, because I noticed the other day that the naming conventions in the document they don't meet the AAPM guidelines. So just if you're looking through that in the next week before Adam's presentation, just take that into account. So some of the volumes are not called what we've just discussed in this presentation, unfortunately. So what Adam's going to he's just going to give you an example of how he approaches his VMAT planning, just in a step-by-step way. He finds it super useful, super easy. He seems to consistently generate good plans. Obviously, I want to say it's not the only way you can create plans, but this is just a nice example of how Adam does it that you could possibly use if you're struggling for a way to get started in these processes. So the team from RCC will share those instructions with you in preparation for the next class with Adam. So there's a link there that you can get the instructions to read. So just to sum up, I guess what I've been talking about, good contouring is absolutely essential to generate great IMRT and VMAT plans. And not only great plans, but accurate plans as well for our patients. Standard naming of contours is really important for all the reasons I talked about before. So about matching the prescription and universality and, knowing what your contours have been used for and who's drawn the contours as well. All of these contours are important to help the optimization algorithm create good plans and to tell it where you can put high dose and where you don't want it to put high dose. So it's often necessary to contour tissue near the PTV that you wouldn't normally think about contouring for forward-based planning or for 3D conformal planning. And it's more than likely, there's not many plans that I see come through these days that do not have any optimization structures in them. So these optimization structures, your Z structures, in addition to your target and organs at risk, are needed to help improve the quality of the treatment plan.